Okay, well, thank you. Stride has asked me to talk about the next generation of biometry, and this is very exciting to talk about. You know, we've had some new biometers come around in the last few years, but they're nothing like this, and I think you're going to enjoy what we're going to be talking about. It's a complete reimagination of biometry, and it combines, for those of us who are anterior segment surgeons, the three basic instruments that you need for your practice are all in this one machine with a small footprint. And have you ever seen anything from Stride that wasn't perfect? Well, this is another example of that. There are no compromises in any of the measurements, and all of the measurements are some of the best that you've ever seen. In addition, the validation criteria that we often talk about applying with biometry, it runs in the background silently. So if you get a little check mark next to the measurement, it means that the measurement is valid. Both eyes in 40 seconds, so think how much that's going to help the clinic. Everything is fully automated. And so what that means is the very least accomplished person in your practice and the very best person in your practice all get the same measurements. So quickly, it does swept source OCT of the entire eye at a very high level of resolution. Everything is in a familiar format, so you don't have to learn about a new device. And the number of scans that are done are incredibly dense, very, very high level of scanning, and I'll show you that in just a minute. The topography is the best topography you've ever seen, and we have direct measurements of the anterior and the posterior cornea, unlike some devices that iterate the posterior cornea, they don't measure it directly. This is a direct measurement of the posterior cornea, and it generates the usual maps. And the pachymetry goes all the way out to the edge, so does the topography. It does a Zernike analysis, which we're going to go through briefly, image simulation, which we use extensively in our practice, and the keratometry is the best keratometry of any device, and I'm here to tell you that. We've been using it now for 18 months. So we'll begin with how it does the OCT. Most of us are used to seeing OCT as these radial scans that march across the eye. This does Mandela scanning, and it's about 3,500 scans compared to the 16 radial scans. So the density of the measurements is incredible. Plus, with each scan, it generates an image, and then the images can be all put together to compensate for motion. So this would be a moderate number of scans, and then a great number of scans, and you can see it makes the image a lot more high resolution. Same here. When you have this much scanning and you put it all together, you can get rid of small saccades of the eye that may take place. The axial measurements are by swept source OCT, and it's in the same familiar format as an immersion A scan, plus you get a B scan underneath it so you can make sure that the electronic calipers are placed correctly. And you can work through a 1.5 millimeter pupil. This is somebody with a camera corneal inlay with 1.6 millimeter aperture. The measurements are completely valid, and it does a very, very nice job. So that's 1.6 millimeters. Now, one of the questions we get asked a lot is, how about dense cataract penetration? The dense cataract penetration is fantastic. By the way, the patients I'm showing are all from my practice. These aren't marketing exercises. These are my own patients. So here's somebody who had retina surgery, has a dense posterior subcapsular plaque, and a hand movement post-vitrectomy cataract. With the Iowa Master, we get nothing. And with our old friend, the Eyestar, we get nothing that's usable. So even in the dense cataract mode, we don't get anything. So no reliable signal. With this device, even though you can see the posterior subcapsular plaque, how dense it is, and the amplitude is decreased, it's still a perfectly valid measurement. And you can see the little check marks next to the measurements, and that means they meet validation criteria. So when we started seeing this, I wasn't exactly sure that I wanted to accept it, so I went ahead and did, on this patient, I did an A scan, and we got the exact same measurement. So it's really quite remarkable how dense the cataract can be and still get good penetration. Now, those of you that have the Eyestar love the keratometry. This is better. And what was done is, instead of the two rings being in the same meridian, now they've been canted. They've been moved one inside the other. So the density of the keratometry is now twice what it was before. And it gives you a real-time video keratographic image, so you can look at the ocular surface to make sure that it's correct. So to keep things in perspective, this is the Eyestar 500 and earlier. We have 3 measurements above, 3 measurements below the horizontal meridian. This is the Eyestar 700. The measurements technically are about 30 degrees apart, but each ring is 60 degrees apart. And if you look at the Lenstar, we have our 32 measurements. They're placed about 22.5 degrees apart. And with the Eyestar, they're now placed 11.25 degrees apart. So there's less iteration that occurs between the measurement points, and the density of the keratometry is much higher. We see a lot of post-refractive patients in our practice. Here's somebody that had about 10 diopters of hyperopia after radial keratotomy. Eyestar and Lenstar got absolutely nothing. With the Eyestar, we get a topographic map. We get accurate keratometry. We get validated numbers. We get diagnostic feedback. The Gould-Strand ratio is high. The patient has an unstable ocular surface. It's amazing what we can do with this. So the Ks on this, not only are they incredibly accurate, they're the same as you would get with the Lenstar, so you don't have to update your lens constants, and they're very, very robust. For a toric lens, this is especially good because we can look at the ocular surface to make sure it's correct. We can look at an axial curvature map that's made at the same time to see that the astigmatism is both regular and it's symmetrical, 2 basic things we need to understand for the toric. What's the orientation of the steep meridian? The machine will automatically draw a line through the corneal vertex and the 2 astigmatic lobes, and then it gives us the power difference between meridians, and then it validates the number for you. So you don't have to have that little index card that we used to have. It does all the validation for you internally. As long as you have the check mark, everything is okay. As far as calculation methods, for the toric lens, we have the Barrett method that does it with just the anterior surface or the measured posterior surface. And we also have an artificial intelligence toric calculator with a posterior cornea done by Doug Koch and Adi Abulafia, and then the IOL portion done by me. So all the calculation methods that you would need to use for a busy anterior segment practice are contained within the device. If you don't have an alignment method in your operating room, you can use this. This is a white light measurement, and basically it gives you a representation of the toric IOL, the steep meridian, the flat meridian, a reference meridian like what we place in the holding area before surgery, the incision location, and then the calculated meridian of the IOL. You can take this, turn it upside down, put it on the microscope head, and use that for guidance. Let's go back here. Okay, so the device gives us these incredibly high-resolution topographic maps because of the Mandela scanning that's done. It also generates a Zernike tree, which is mandatory before we place multifocal IOLs. And it based image simulation. So if you have somebody that comes in who's unhappy with their multifocal IOL, you can show them what the image simulation is like and explain to them that maybe it wasn't a good idea to put that lens in after 8 diopters of myopic LASIK. So it's a wonderful way to screen for IOLs and also look for the reason for unhappy patients. So this would be the image simulation for normal eyes, say somebody with normal Ks with an aspheric IOL that adds negative spherical aberration. This would be somebody that had both spherical aberration and coma. So this would be like an example of the discussion we would have. Here's somebody that had 8 diopters of myopic LASIK. They have a decentered ablation, so there would be the flattest portion, and that creates spherical aberration, coma, and then another aberration called trefoil. But you can see the spherical aberration is very high, and what that gives is a characteristic halo and glow to the image. And here's the coma. The coma generates image duplication and displacement, the vertical coma and the horizontal coma. The topography goes out to 12 millimeters. It goes all the way to the limbus. So think about the topography you have right now. Most of them are 8, 9, maybe 10 millimeters. This goes all the way to the limbus. So let's say, I don't know how much keratoconus we have here in Brazil, but I was in the Middle East not long ago, and where maybe 19% of the population has keratoconus. And the question is, does somebody have pellucid marginal degeneration? They have the 2 kissing doves, and people think that was it. But if you don't see the periphery, you can't make the diagnosis. So there's the periphery, that looks normal. So this would be keratoconus and not pellucid marginal degeneration. If you have a practice that's busy with keratoconus, you need to look at difference maps, and that's how we track the disease, along with the Balin ABCD method. And this can give you all the different reference maps that you may need in order to track keratoconus. So any way that you want to set up the difference maps, it will do that for you and then track that over time. So for keratoconus, this is a very useful device. And the software in the future is going to have epithelial mapping, which allows us to add a fifth category for the diagnosis of keratoconus. So we can diagnose these patients very early, perhaps in their teens, the earliest method for diagnosing keratoconus, and you wouldn't need ectasia for that. Because this is a direct measurement of the posterior cornea, the ectasia display section is incredibly accurate. And one question I have is, could this perhaps replace the Pennicam for that? Because that's an old and trusted friend in this area. We've all used it for keratoconus, and the answer is yes. It gives us the same pachymetry progression that we're used to seeing, as well as the Balin ABCD method of staging and following patients with keratoconus. And then one thing that's interesting, it also does anterior segment OCT. And because of the Mandela scanning, we get many, many measurements. It's a very high resolution device. So we can get multiple cross sections. We can use this for screening for narrow angles. Here's somebody with an asymmetric angle narrowing. On one side it's 14 degrees, on the other side it's 21. And we use this for tracking our patient. So this would be the narrow side with an angle of 14 degrees. And the algorithm that we use, if it's more than 16 degrees, we just follow these patients, but follow them closely. If it's 15 to 11 degrees, we plan for an iridotomy or phaco, and lately, phaco has become the standard of care for narrow angle rather than just a peripheral iridotomy. And if it's less than 10 degrees, we plan for cataract surgery as soon as possible, because these are the people who may occlude for us. So this is a very objective way of measuring the anterior chamber angle and following people over time that's very reproducible, because the OCT is very high resolution. The OCT goes out to 18 millimeters, so you can get beautiful anterior segment images. Here's somebody with a penetrating keratoplasty, people with intacs. Here's somebody with pseudophakic bullous keratopathy, and then the same thing after DMEC. We do a lot of DMEC in our practice, and it's nice to be able to show what this looks like before and after. So basic in summary, this is a completely new way to think about a biometer. It's more than just axial measurements. It's the best keratometry you've ever seen. Also very, very good topography that can replace the topography you have right now, and very good anterior segment imaging. And these are the must-have instruments for any anterior segment surgeon. And it can, for many practices, it can replace 3 different devices. None of the measurements, none of the imaging are compromised. Everything is very, very good, exactly what you would expect from Hog-Streit. And as far as office efficiency goes, both eyes are done in 40 seconds, and all the measurements are validated, so you don't have to spend time with the validation criteria card making sure everything's correct. If you don't have a little check mark next to the measurement, then you just delete and repeat. So we've been using this now for about 18 months, and it's just absolutely amazing. And I was part of the development team of the Eyestar. It's an old and trusted friend. I love the Eyestar. This is the next generation beyond that. So what we really have here is something even in addition to the best biometer. What we have is confidence. And that's really what this is all about. How many of us love to go into the operating room feeling very, very confident about what we're doing. And of course, the end product is happy patients. And we have very happy patients with this. So this is what we're using and what we enjoy very much. Thank you.
Alô, alô. Muito obrigado, Dr. Rio. Apesar do Porfírio ser o homem da biometria, certamente vou passar a palavra para ele, o homem da córnea aqui na mesa ainda sou eu. Dr. Hill, how important it is to get the information of the cornea in a high-speed measurement?
Yeah, it's very important. But remember, the Ks are done by reflective keratometry. which is the basis for all IOL calculation devices. So that's still the standard. The Mandela scanning takes place very, very quickly. And again, we do the right eye and the left eye in 40 seconds. So it happens very, very fast. So for a very busy practice, if you were to have one or two of these, think of how many patients you could put through the clinic. And if all the measurements are validated, you don't have to think about, is this correct or not? You can just move on to the calculation method. So as far as throughput and efficiency, it's really spectacular.
Bom, mais uma vez, boa tarde a todos. Eu sou fã do Eyestar, né? Uso há quase uma década. Sou fã de biometria também, então vou comentar algumas coisas com vocês. O Eyestar, a minha experiência com ele foi de duas ou três semanas, mas como as Dr. Hill told us, Eyestar is a Eyestar steroid enhanced, an steroid. Então, o Eyestar já achava bom porque ele tem o dual zone, né, 32 pontos. As Dr. Hill showed us, dual zone better right now. More robust. O AL do Eyestar é fantástico, só que ele tem 820 nanômetros. Agora o Eyestar com 1055 nanômetros, 1060, não tenho muita certeza. Agora passando por cataratas densas, né? Tem a fórmula Hill RBF inside the Eyestar, version 3.0, RBF 3.0, que é uma fórmula fantástica nos trabalhos do Douglas Koch, com 92%, 93% de mais ou menos meio. Eu uso muito a fórmula do professor Hill. Agora, com a parte tórica, né, com o nomograma do Abulafia-Co, o sistema de mandala, né, o escaneamento em mandala, que provavelmente deve melhorar muito, como ele nos mostrou. Agora, o Eyestar, para mim, com a minha experiência de 2, 3 semanas, foi muito interessante, porque ele agora é um Eyestar com um bom topógrafo, com um bom aberrômetro, né? E como o Dr. Hill nos mostrou, é the best topographer we ever seen. Então, o Eyestar promete muito, né? Para quem já era fã do Eyestar, agora a gente tem o Eyestar. E como a gente tem falado nas nossas aulas, uma boa biometria, ela não vem só com um biômetro, tem que ter um bom topógrafo e tem que ter um bom aberrômetro. E agora, com o Eyestar, a gente pode ver a aberrometria para descartar uma trifocal, por exemplo, se tiver muita aberrometria. Então, assim, a nossa expectativa com o Eyestar, apesar da minha experiência ser de poucas semanas, foi muito, muito enriquecedora. É um Eyestar, realmente, o Eyestar já era um aparelho, eu adoro o Eyestar, eu prefiro, às vezes, o Eyestar até que alguns OCTs, né, não vou citar aqui o nome, mas eu até prefiro que alguns OCTs. Então, assim, a gente tendo agora o Eyestar, eu acho que é um mundo perfeito para nós, de matéria de biometria, com excelente topógrafo, mais uma vez, com um bom aberrômetro.
Now you have a piece of equipment with interferometry, and also you can the aberrometry of the cornea. That's probably going to increase the precision of your choice of IOL. So how is that going to impact the biometry if you have the aberrometry of the cornea with the same equipment now?
Well, the aberration profile doesn't really change the IOL power calculations. The calculations are based on second-order aberrations, which is defocus and first-order astigmatism. But what the aberrometry gives us is a wonderful screening tool so we don't get into trouble with multifocal lenses, especially diffractive multifocal lenses, prior to surgery, or if somebody comes to you unhappy with their vision and they've had a multifocal lens, the very first place to go is to look at an aberration profile, and many times that's going to tell you the story as to why they're unhappy with their vision. Remember, all aberrations do is they tell you a way in which contrast has been lost, and each aberration does it in a specific way. Spherical aberration produces that characteristic halo and glow. Coma produces image duplication and displacement, and in the setting of a diffractive multifocal lens, elevated aberrations can really be a big problem. So that's what it's used mainly for.
Rosatelli.
And I think I recently discovered Dr. Hill's secret about being so proficient in everything biometry related. He has a dog, and his dog's name is Zernike. So that's, I think that's cheating.
Okay, so in our practice, I worked with Wolfgang Haggis for 20 years doing the ULIB site that many of you are familiar with. And the standard for calculation accuracy during Wolfgang Haggis's lifetime was between 74 and 78%. That's now improved to about 80 to 82%. And with the right biometer, every person in this room can move to about 90% with the accuracy. But it involves one extra step that I'm sure many of you are doing, and that is to optimize the ocular surface prior to doing biometry. The keratometry is one of the major sources of error for IOL power calculations. And if you have an optimized ocular surface, the accuracy can go up 3, 4, even 5 percentage points for every single person. But for now, set 90% within half a diopter accuracy as your goal. With a little bit of attention to detail, I'm sure that everybody here can achieve that.
Só mais uma coisinha. Hoje em dia, na biometria, a gente não erra mais no AL, né? Os aparelhos são muito bons para AL. A gente está errando na ceratometria. E, no meu ponto de vista, o melhor aparelho de ceratometria é o Eyestar. Esse dual zone com 32 pontos. E agora o Eyestar melhorado, porque agora, como o Dr. Hill falou, ele tem mais ele pega uma zona mais, você praticamente não tem zona cega, né? Então o reforço do Eyestar com relação à ceratometria, eu acho que é um ponto positivo demais nesse novo biômetro da Hagstride.
Muito bem, Eduardo.
Não, é só para falaram da lente, não tem mais o que falar, né? Já falaram tudo, mas essa lente, quem nunca usou a lente dessa plataforma, o ejetor dela, na minha opinião, sem dúvida, é disparado o melhor do mercado, né? Você ainda tem a opção de injetar ou rosquear, mas é 1.8, muito suave, quer dizer, para mim, como ejetor, não tem nenhum igual no mercado.
O injetor deles tem a parte da frente, você pode ou recuar ou ir para frente, você pode entrar dentro do saco capsular. Eu gosto de injetar a lente toda já dentro do saco capsular. Então você entra por 2.2 ou 2.4 com esse injetor fantástico da Roya e você já consegue, como ele tem aquela boquinha mais para frente, eu não recuo, deixo ela grandona e você já consegue colocar a lente da Roya dentro do saco capsular. Não tem que ficar, às vezes, pegando o Sinsk para empurrar, não. Todas as minhas lentes já vão direto para dentro do saco capsular com as duas alças dentro do saco capsular.